It's Anthony Chadwick from the Webinar Vet, welcoming you to another episode of VETchat. Today we have our CFO on the line, Buddy, who is just wanting to join us today. And of course, we also have Ron Ofri, the very esteemed and very good friend of mine, ophthalmologist, based over in Tel Aviv. Ron, obviously, before we start, just want to say that, our thoughts are with you in these difficult times that you're in, and let's hope for a better 2024, hey?
Indeed. Yes, I know this is going on the air in February, but we're recording it mid-December. And yes, let's hope for a peaceful 2024.
We go back a long way, Ron. I'll start with my visual aid, which is this beautiful book that you gave me when we met in, I think it was it Seville or Valencia in
Seville,
at the
SEVCVT.
SEBC a few years ago, and it's much treasured by me. Obviously, we've got all the signatures in as well, and ophthalmology is closest to my heart. As you know, I did dermatology, but I spent a lot of time working at the Animal Medical Centre in close collaboration with Pip Boydell, and we often talked about eyes and skin being connected. There were certainly issues around eyelids and things that would mean that both of us could have an opinion on it. So this has always been a treasured part of my bookshelf. So thank you so much again. And thanks for all the contributions you give to Webinar Vet, because you've done many webinars for us over the years. As we talked recently, some of those possibly need refreshing, because one of my other favourite lecturers, apart from yourself, is a professor retired now up at Texas A&M, Mike Willard, who said quite often on lectures, everything I taught you 10 years ago was a lie. I just didn't realise. So the veterinary medicine is always progressing, and some of the things we talked about 5-6 years ago, we probably want to have a slightly different angle on now, don't we?
Yes, let's be diplomatic and call it a mistake rather than a lie.
Yes, I agree. I will let you get away with that one. But yeah, it's really great to have you on the podcast.
Pleasure to be here. Thank you for
Obviously,
inviting me.
a great friend of mine in the veterinary profession. We've known each other a long time, but perhaps those people who don't know you as well, give us a little history of your veterinary history, as it were.
Yeah, well, people always ask me how I became interested in ophthalmology, and uh, like many other things in life, it's thanks to a great teacher. My personal story is that actually I am a member, or I was a member of the charter class of our school, which opened up in 1985. Prior to that, there was no veterinary school in Israel. They opened in 1985, and similar to the American system, you had to have a pre-vet education in order to apply. I was fortunate enough to just graduate at the right moment with a degree in biology. I applied and I was accepted. But since it was a new school, they lacked teachers and professors in many areas, in many disciplines. So, what they did is invite speakers from overseas to teach specialities for which they had no instructors. And really, they invited some of the biggest names in the time. Bob Hamlin for cardiology, and Cornelius taught us the liver disease, and Kaneko taught us biochemistry. Maybe these names don't mean too much to the younger audience, but in the 1980s, they were really the leaders in their field. And for ophthalmology, they brought Kirk Gillette, who is considered by many the grandfather of veterinary ophthalmology. He has written the Bible of, or edited the Bible of veterinary ophthalmology for many years. He's first editor of the journal. At the time, he was dean of Florida, and he came over to Israel to teach us ophthalmology for 3 weeks. What they did is those people would come for 3 weeks, and they would teach us everything from A to Z. So, like,
Yeah.
Kirk came over and taught us the embryology of the eye, the anatomy, the physiology, pharmacology, clinic, surgery, and pathology. 3 weeks of pure ophthalmology, and I fell in love. I kept in touch with him when he went back to Florida. That was back before email was invented. So we'd write letters and stick stamps on the envelope and write each other. But we kept in touch. And when I graduated, I told him I want to come to Florida. And he said, come on over. And I did. And I spent 4 amazing years at the University of Florida training in veterinary ophthalmology, getting my PhD. At the time, it was really the best place in the world for veterinary ophthalmology. They did want me to stay there when I was done, and I'm still remembered as the only person in the history of Florida who turned them down. But home is home, and after 4 years, I was yearning to go back home. So I packed my bags, and I've been here at the Hebrew University of Jerusalem ever since.
What a great story. And I don't think I've heard that story before. Did Kirk go to stay in Florida, or did he go to Cornell, or who was in Cornell?
No, in Cornell we had Tom Kern, I guess, who's maybe one of the oldest guys. Later, Gus Guiri moved to Cornell for many years. Kirk in early stages of his career was in Minnesota and maybe Kansas, I don't remember. Then he migrated to Florida with a colony of beagles with glaucoma. And I know
Yeah.
glaucoma is a subject of great interest to you. Uh, a colony of beagles with inherited glaucoma, which he kept for 30 years. You'd walk into his office, and on the wall there'd be a family tree going back as of 30 years of beagles with primary open-angle glaucoma, and those beagles generated lots of grants, lots of papers, lots of PhDs, because they were a model for human glaucoma.
Hmm. I remember I won the Frank Beatty Travel Scholarship in '97 and went to Cornell to do dermatology and ended up spending time with Danny Scott and Bill Miller, which was fantastic.
Mhm.
But I woke up one day with a really painful eye and didn't know whether it was some sort of allergy or whatever, but it felt like there was something grating on the eye. And the ophthalmology department was next door to the dermatology department. So I went to see them and there was nobody there. And they said, oh, come back a bit later. And I came back and there's still nobody there. And my eye was really, really sore. I ended up, the end of the day, I found somebody from the ophthalmology department. They stuck some lignocaine, procaine into my eye and diverted the lower lid and found a nice piece of grit in there that had been
Mhm.
rubbing up and down on my cornea, already abrading the cornea a bit, realizing
Mhm.
how painful that can be, which I've since suffered after a piece of eye surgery, when there was another little abrasion. Corneal abrasions, ulcers are painful things. But of course, once the piece was taken out, it was so much better. And it was then that I got even more gratitude for ophthalmologists because that was a painful, painful eye. And I think you've done webinars for us on that sort of acute painful eye. There can be all
Yes.
sorts of things that can get into eyes and cause problems, can't there?
Yes, indeed, and you mentioned it was something below your eyelid. Let's not forget that our patients have three eyelids, so there is
Yeah,
even more room for foreign objects, foreign bodies
yeah,
to irritate the eye. And you're right, the cornea is one of the most richly, and not one of the most richly innervated
mm,
tissue in the body, so they can be very painful. Strangely enough, it's the superficial cornea which is richly innervated. Actually, there are fewer sensory nerves in the deeper cornea, so in a bit of a paradox. Superficial ulcers are more painful than deep ulcers, and
yeah.
sometimes when deep ulcers, and when an ulcer progresses from superficial to deep, the owners think, "Aha, things are getting better because the dog is less painful," when in fact it's less painful because
Yeah.
there's less nerves there, but in fact it's worsening, it's just gotten deeper.
Going back to glaucoma, which I know is one of your favourite, or should we say one of those subjects that you battle with the most in ophthalmology.
Yes, I call it my
I obviously
nemesis.
Yeah, your nemesis, as you said. Um, I have a family history. It's presents that have been given to me by my grandfather, who I don't remember. I was 2 when he died. He lived with us at home, and he went blind with glaucoma, and that was obviously in the late 60s. And then, of course, my mum and dad both had glaucoma from both sides. So my granddad was my mum's father, and then my dad developed glaucoma, but they were both in their sort of 60s from what I can remember when they developed it. I have, I had very, very good vision up until my mid 40s. And I went to see my auntie in Australia, who unfortunately was dying. I wanted to see her before she passed. And she said, Anthony, your eyes are really, really red. You should go and see
Oh.
an optician when you go back. Because I'd never been to an optician, even though in the UK, once you reach 40, if you have a history of glaucoma in the family, you can get free consults. But my eyes were so good, I didn't wear glasses. I could see really well. So I never went. And then post coming back from seeing my auntie in Australia, I went to the optician. My eyes were possibly starting to just blur a bit. So he said, you
Mhm.
might need, a light pair of glasses, but actually the right back of the eye doesn't look in a great shape on the retina. So I was referred to the ophthalmologist, and obviously the optometrist had also found that I had high pressures in my eye as well, which is
Mhm.
obviously can be a sign of glaucoma. And then I had the diagnosis of pigmentary dispersion syndrome.
Oh.
The only positive, Ron, I was 45, 46 at the time, and they called it young person's glaucoma. So there's always a silver cloud to every lining. I came back feeling good about the fact that people were still classing me as a young person at 46. But otherwise, um, one of the things personally has made me do is appreciate, although my sight isn't as good as it was, I, need to wear glasses for long distance. You actually appreciate your sight a lot more when you realize that maybe it isn't as perfect as a young person. You take a lot of these things for granted, don't you?
Yes, indeed. And, numerous surveys show that that's the one sense that people are most afraid of losing. And yes, you're right in so many ways. Because the damage caused to the retina and to the optic nerve as a result of glaucoma is something that we cannot repair. The retina does not regenerate, the optic nerve does not regenerate. So when you're diagnosed with glaucoma, whether you're a human or a canine or a feline patient, um, the aim of treatment will be to lower intraocular pressure and to stop further damage. But any damage that has occurred prior to the diagnosis and initiation of treatment, any vision that has been lost prior to the initiation of
Mm.
treatment, will never recover, which is really a problem because, as you know, in veterinary medicine, many owners would show up at the terminal stage, really, when
Yeah,
it's too late, when the eye is already irreversibly blind. They're not as fortunate as you were to go to an optician and he looks at the retina and says, "Oh, you should go see an ophthalmologist."
mm.
They sort of it creeps up on them and they don't realize it until it's too late. And yeah, often when presented with a patient with glaucoma, we are really concentrating on the unaffected eyes in cases
Yeah,
when it's inherited glaucoma. This one is still seeing. Uh, I can fight for it. I can try and preserve vision. This one, I'm sorry, may be
too late.
lost. Yeah, and that's a point. You mentioned the webinars. I always bring up, when in doubt, treat the unaffected eye. This affected eye may be lost. The unaffected eye is still visual. That should receive prophylactic treatment.
Do you want to become a part of the largest online veterinary community in the world? The Webinar Vets membership is the perfect tool to easily complete your veterinary CPD or CE. Watch webinars anytime, any place, on any connected device. Become a member today and explore our library of over 2,000 premium quality webinars. We also care about the environment as well as your CPD or CE. That's why we plant trees for every one of our members. To find out more, visit thewebinarvet.com/memberships or click on the membership tab on our website.
Sometimes, obviously, you get a lens luxation that can cause glaucoma. So removing lenses quickly can obviously save the eye from going into terminal decline. Do you think
Absolutely.
should we, as part of clinical exams, look more seriously at doing tonometry? Because it's something, I don't think I ever did in veterinary practice. Um, is that something that we should be doing more routinely, perhaps in older animals or in certain breeds that are more prone?
I would say in certain breeds, definitely. It is something that should be done, and you can find lists of breeds with inherited glaucoma. However, if you're talking, and yes, every veterinary clinic really should have a tonometer in
Yeah,
order to measure intraocular pressure. Maybe not as part of the routine screening, but definitely to manage both your glaucoma and uveitis cases, you do need a tonometer. I'd say that if you want to add an ophthalmic diagnostic technique to your arsenal, always practice ophthalmoscopy on every patient that walks into your clinic.
yeah,
Because number one, it's not an easy technique. It does require practice. And number two, there is lots of variations in the appearance of a normal fundus, both, especially in our canine patients. So if the first time you're trying ophthalmoscopy is when an owner comes in complaining of a blind patient, I'd say it's pretty much a waste of time. If you haven't mastered the technique, if you don't know
yeah.
to recognize normal variations, you'll be lost. So I always say every patient that comes into your clinic, whether it's for vaccination or a flea problem or diarrhea, just take a quick look in the eye, 2 seconds, just to A, familiarize yourself with the technique, and B, familiarize yourself with the normal appearance of the fundus. And I find also that clients always appreciate it. It's like they saw Grey's Anatomy, that the doctor always examines the fundus, and wow, my dog got the same
Yeah.
treatment. It always impresses them.
And really, with glaucoma, we're looking for atrophy potentially of the blood vessels around, but you also get this sort of halo aura effect around the actual fundus as well, don't you, with glaucoma?
Yeah, well, there's lots of signs of glaucoma for owners to notice. As you said, red eye would be one of them, blue eye due to corneal edema. Sometimes, if it's really a sensitive owner, they would notice that the pupil is more dilated than normal or doesn't constrict as much as in daytime. And those are really alert owners who'd come at an early stage. But really, if I could go back to the irreversible damage that is being caused to the retina, one of the most exciting things in areas in glaucoma research is what we call neuroprotective treatment. And the idea behind that is that when we give drugs to lower intraocular pressure, it is really a losing battle. Once glaucoma is started, we can try this drug or that drug or drug combination or maybe surgery. Within a year or two, most of our veterinary patients will become blind, despite and humans also become blind, despite the fact that we lower their intraocular pressure. So neuroprotection, which actually began in neurology, is a new therapeutic approach whereby you say, forget controlling intraocular pressure because it's something we do not excel in. Let's concentrate on actually protecting the retina and protecting the optic nerve from damage. And there are lots of promising drugs. At least in rodents, they work very well. Unfortunately, they work less well in humans and dogs that can protect the retina and the optic nerve from damage despite elevated intraocular pressure. And that, I think, therein lies a big hope for glaucoma patients, that we combine hypotensive treatment with treatment to protect the optic nerve and the retina and prevent this damage.
And looking at pressure wise, similar in humans, sort of 20 is where we start to get concerned about pressure
Mhm.
numbers, in the same in dog and cat.
Yeah, yeah, actually, that's a interesting subject unto itself. There are numerous papers debating the subject of what is safe IOP, And you've touched on a very interesting point here, because really, glaucoma is one disease that I always tell my students, the more we learn about it, the less we understand it. When you and I were students, glaucoma was an easy disease. Pressure goes up, you have glaucoma, pressure comes down, you've cured glaucoma. And with the years, we've come to realize that really glaucoma is a multifactorial disease, at least in people, and there are many risk factors in play. Elevated intraocular pressure is probably the most common and most significant one, but the immune system plays a role in it. Blood circulation in the retina plays a role in the pathogenesis of glaucoma. And lots of other factors that come into play, to the point where in people you actually have what is called normotensive glaucoma, meaning glaucoma with all the hallmarks of glaucoma, with the damage to the optic nerve and the retina, but it's normotensive. Pressure would be normal, and that is about 1/3 of the glaucoma cases in people, which is really scary. So there is really no safe IOP for some people with problems with the immune system or blood circulation in the retina. It may be lower, maybe 12,
Mm.
13, 14. For others, it may be 20. It's really individual because of all the other factors that are in play.
Yeah, no, it's fascinating. And I actually have pigmentary dispersion syndrome, which the doctor has explained will probably get better as I get older. So I'll reach a point in my 60s, hopefully, where actually the pressures would almost drop naturally. And then it's the damage that's been done over the last, 10, 15, 20 years. And of course, then your eyes deteriorate as you get older as well. You lose neurons. So it's
Yeah.
how you can slow that progress down as people are living older and potentially dying before you go blind, I suppose, is the way that you look at it. Is pigmentary dispersion syndrome a problem in dogs or cats? Is that a disease?
We do have it in a couple of dog breeds, not in cats, but Cairn Terriers have a similar disease, pigmentary glaucoma, and Golden Retrievers and a few other breeds have a type of glaucoma caused by cysts that are in the eye that burst and they disperse pigment, causing secondary uveitis and glaucoma. So uveal cysts, in many breeds, it's an incidental finding. It's just a nice balloon floating in the eye. But in especially in golden retrievers and a few other breeds, if you see it, it's cause for concern because it may pop, disperse
Mm.
pigment, and as you say, cause pigmentary uveitis, pigmentary glaucoma.
And the pigment is interesting because it sort of blocks the angle, doesn't it?
Right.
And then you actually need the macrophages to get busy in actually eating up that pigment. So I've
Absolutely.
ended up in the situation where drops weren't working. I've had surgery, which has been an interesting. It's not been a trabeculectomy. This particular surgeon does viscocannulostomies, which is sort of he doesn't go right through the membrane because eye surgery with trabeculectomies and so on. There's a danger you can drop the pressure too much, can't you?
Right. Yes, surgery is another interesting aspect of glaucoma. As you say, if you're a general practitioner and you feel that you are unable to control pressure medically, then you should definitely refer the patient to a veterinary ophthalmologist because we do have some options. For some surgical options, including laser and other means of partially destroying the ciliary body and lowering production of aqueous humor. We do have shunts and other surgical procedures similar to what you're describing to increase outflow from the eye. So we do have surgical options, and they would be a reason to refer your glaucoma cases to a specialist. As far as general practitioners go, I regret to say that the most uh, the surgery you'll be performing most commonly is enucleation, unfortunately,
Yeah.
because often we do end up with an eye that is irreversibly blind, because I said the damage is irreversible, and painful because we're unable to control pressure medically, in which case enucleation may be the best option. And that's
Yeah.
another thing I've stressed in my webinars, a very important point. There is a very important difference between cases of acute glaucoma and chronic glaucoma. Because
Yes.
if the dog has become blinded with acute glaucoma, the owners can see that it's painful and they will not argue with you when you recommend enucleation. However, in cases of chronic glaucoma, when it's sort of crept up on them very, very gradually, when you recommend enucleation, they'll say, what the heck? My dog is not painful. It eats, it drinks, it plays, it goes outdoors. It is absolutely fine. No, it is not in pain. And the analogy I'll always give them in this case is think of glaucoma as a migraine. Okay,
Yeah.
people with a migraine also wake up, they brush their teeth, they go to work, they come back in the evening, they watch some TV, they go to a pub with a friend. Yeah, just like a dog, they walk, they eat, they play, but they are suffering constantly because of the
Yeah.
migraine. And same with those canine patients with a chronic glaucoma, they are in constant pain. And the proof is that when I win the argument and I convince them to enucleate, they come back 2 weeks later for removal of sutures. And the first thing they'll say is, the dog is 5 years younger. It is
Yes.
so much more active. It is so much more playful
Yeah.
because we have removed the migraine. So don't take the owner's word for it. Think of the migraine analogy and insist on enucleation. And we've got surveys out, a couple of them published in the United Kingdom, showing 96% satisfaction rate for owners who
Mm.
agreed to performing enucleation in their pets.
Dogs are resilient, aren't they? And they don't show pain. They don't, it's not always in their interest to show it, and they will cope with life.
Yep.
The same analogy is that dog that you diagnose in the waiting room because you can smell the rotten teeth, and you take those teeth out, and the dog comes back a week, 10 days later with the same thing. My dog is 5 years younger. So its pain is insidious. And if it's happening chronically,
Mm-hmm.
people don't recognize it because the dog has been like this for months, potentially years.
Right.
Take that eye away, take those teeth away, you've taken away the source of pain. The dog cat improves immensely.
Absolutely, though. That reminds me, I was once giving a lecture alongside a dentist in China back in the days before COVID when we could still visit China.
Yeah.
And we were talking about enucleation. He was talking about teeth extraction. I told him, gosh, you're so lucky. You've got 30 some teeth you can remove. One, two, three, four. No, I can take out one eye. I take out the other eye, I'm done.
Yes.
That's all I have. Yeah, so he's much more fortunate in that, yeah, we ophthalmologists, we regard enucleation really as euthanasia. I'm killing my patient. And if I take
Yes.
out the other eye, that's it. I've nothing to do. But as I said, in the case of glaucoma, it really needs to be done when the eye is irreversibly
Yeah.
blind and you can't control pressure.
And actually, dogs cope so well with sense of smell and things. Even a totally blind dog
Hmm.
can get around because he or she is familiar with the house setup. It's amazing how well they will do, isn't it?
Absolutely. And, we as ophthalmologists or as veterinarians, we have many blind patients, not just because of enucleation, most commonly because of retinal atrophy or
Mm.
long-term uveitis, and they'll be irreversibly blind. But like you say, they can cope very well, and there are lots of websites out there and help guides and books with lots of tips, and you should always refer owners of blind patients to these websites or maybe have them buy one of these books. They are full of wonderful advice and wonderful heartwarming stories about, like you said, how well the animals can cope while being blind. It is definitely not a death sentence.
Ron, I think Buddy is just saying he feels that we've been too dog centric and we can't really call this a podcast because cats haven't been mentioned enough. How about just the last couple of minutes? Where does glaucoma fit in cats? Is it as common? What are the common conditions within that? And how are we best to deal with cats who sometimes can be a
Yeah.
bit more difficult to dose and things than dogs anyway?
Yeah, thank you for bringing it up. So in dogs, There are studies that show us that about 50% of the glaucoma cases are due to uveitis, 50% of them are due to inheritance. And as I've said earlier, it's the inherited cases where you should treat the unaffected eye. In cats, glaucoma is nearly always secondary to uveitis. There is inherited glaucoma is very rare in cats, so it's nearly always secondary to uveitis, and therefore, when you're presented with a cat with glaucoma, you should suspect uveitis, which means you should suspect some primary disease that triggered the uveitis, and that cat needs a comprehensive workup, physical exam, blood work, serology, chest x-rays, whatever, in order to look for the primary reason the primary disease, the systemic disease which caused uveitis, which caused glaucoma. Same, I should add, for cataracts in cats. In dogs, the two most common reasons for cataracts are diabetes and inheritance. Neither one of them is a common cause of cataracts in cats. Again, in cats, the most common cause for cataract in cats, is uveitis. So again, just like with glaucoma, whenever you see a cat with cataract, suspect uveitis, suspect the primary disease, and do the workup. Though I should mention in this regard that studies show us that you can do a comprehensive workup, and in 40-50% of the cases, you will come up empty-handed. You will not find a primary disease. It will be idiopathic uveitis that cause glaucoma or that cause cataract. And this is something you should tell the owner beforehand. You should tell him, hey, I'm going to do all this workup, which is going to cost you hundreds of pounds. It's important to do the workup because maybe your cat has toxoplasma, maybe it has fungal disease, maybe it has this, maybe it has that. We need to do the workup, but be prepared that I'll come up empty-handed. It will be idiopathic uveitis. And it's always a good idea to warn owners in advance that they're going to spend hundreds of pounds and everything may be normal. Tell them that the literature shows
Yeah.
us it happens in 50% of cases.
Buddy, was that okay? Was that a good answer? He seems happy, Ron. He seems happy. Although he's not paying attention, he's got his back turned to you, which
Right,
is
but
slightly rude. So I apologise, Ron, on behalf
apology
of
accepted.
the cat.
Apology accepted. Dogs have owners and cats have staff. We're all staff to our cats.
Exactly. I am his butler.
Yeah.
So and Chief Petter when he feels like he needs a little stroke and a cuddle.
Mm-hmm. He let you know.
Ron, it's been fabulous chatting to you. Also learning some about the ancient history, which I think is fair to say now from the 80s that I wasn't aware of. Particularly the connection with Kirk Gillette, who is obviously such a big figure in ophthalmology. So you've been very fortunate to have that link with him.
Absolutely. And it was a pleasure. I just saw him at the ACVO meeting in October, 2 months ago in Boston. It was a real pleasure to team up again with all my former mentors from Florida. As I said at the beginning, good teacher is what it's all about.
It makes a big difference, and it's always good. My wife is a teacher. It's always nice when we tell them how good they were. I remember my professor of animal husbandry, Ron Anderson. We were there for 100th anniversary of the vet school, and this was a professor, and I was still a relatively young vet, saying how much I'd enjoyed his lectures and how good he was, and you could tell he was genuinely touched. So if people are listening, feel free to go out and show gratitude and thanks to the professors and the teachers who've made a difference in your life. They're never quite sure, but they can have a profound effect on people, can't they?
Absolutely. I'll second that. Definitely.
Ron, thank you so much. I know how busy you are, so giving some time up is a gift to us at VETchat and the webinar Vet, and I really appreciate it. And I've certainly learned a bit more about my glaucoma as well. So thank you so much, Ron.
Thank you for having me. It's a real honor and a real pleasure. And wish you a merry holiday season. And as we said earlier, a peaceful 2024, both to
Yeah.
the people in the Middle East and people in the Ukraine and wherever throughout the world.
All over the world. Yeah, absolutely. That this is what the season is all about.
Yes.
Thank you so much, Ron.
Thank you.
Thanks everyone for listening. Hopefully see you on a podcast or a webinar very soon. Take care. And this has been Vet Chat. And this is Anthony Chadwick. Thank you very much. Bye-bye.
Thank you. Bye-bye.